Thank you. So I'm Elizabeth Plant. I'm the lead for the Taranaki Collaborative. I have to say we do apologise for the lack of dashboard, and also I'm not going to have overheads. This has been due to unforeseen circumstances outside of any one of the team's control. But the team is a great team, and we've got Tub Sanderson here today. It's the first exposure to the learning sessions, and we've had all the team come through the various sessions. So I've lost my notes, which is a great start, isn't it? So we identified our problem, and we identified clearly 3 areas from our trigger tool data. So opiates, as with most people, is the highest medication of adverse drug events, 29.7% in our case. Constipation was the highest category, and 22.6% for our baseline trigger tool identification purposes. We also identified through the Atlas data Taranaki's got an oxycodone problem, so much so that with Capital and Coast being so good with their management of that, we get addicts coming up to Taranaki to get their oxycodone from Capital and Coast. And our trigger tool data identified that we had a 3.5 times adverse drug event to the published data, so that was a red flag for us. Also, we'd done an audit on discharge, and we identified a number of issues around the quality of prescribing, which we extrapolated to the fact that it would lead to harm. And so those are the 3 areas with our 3 aims. So our first aim was to reduce constipation in the orthopaedic ward, harm associated with it, by 25%. For constipation, it was greater than or equal to 3 days, which proved to be a problem, as we've identified already. We also have an aim to reduce oxycodone prescribing by 50%. The harm, obviously, there is addiction, but we just decided we'd try and do it while we were doing the collaborative work. And our third aim is to reduce harm, particularly nausea, vomiting, constipation relating from discharge process by 25%. So with our baseline, there were a number of challenging areas, as we've all identified, particularly with constipation. Our audit, we only were able to get small numbers, skewed our data. The length of stay, greater than or equal to 3 days. When we were doing our baseline, if you saw somebody, if we were doing it at the time, you intervene, and so therefore the harm doesn't occur. We had introduced ERAS in 2014, and this had a laxative co-prescribing included in it. So actually our harm was a lot less than we perceived when we actually went in and had a look at it. We also found really poor documentation in the notes, which meant it was really difficult to identify it, and there was a whole increased awareness around this area. So we've now resolved we'll go back to our trigger tool data, and looking at that in 2011-12, it was 22% constipation harm identified. With ERAS being introduced, it dropped to 9.4%. So now we're going to go back and look at the period just before we started this to confirm that 9.4%. We did an audit and got a 10% constipation rate, but it was only 1 patient out of 10, because the 10 patients with the length of stayed longer than 3 days. So it's meaningless, really. We've done a number of process measures that we've put in place, so we've implemented They're part of accepted practice now. So I'm sorry about the theory behind this, but I think there is a challenge when you've got something and you're putting it into place in a busy hospital. So maybe that's something we need to discuss about the reality of the theory versus the practical. So we've got co-prescribing, co-administration, we've got a protocol, and we've got bowel activity documentation. It's now part of the rapid round, and also the verbal and written handover. And so it's improved dramatically in terms of documentation. We've got induction training for our doctors, done by our doctor induction training, and our acute pain team for nursing, so that's incorporated now in business as usual. We've had posters, and we've done a grand round, and so we had great attendance as our grand round, because if you get a doctor to present, you get everyone turning up, whereas if it comes from the pharmacy department, much lower turnout. With our discharge audit on baseline, with the audit with discharge, we did a lot of process measure audits, so we've got a lot of measures around process, around the poor quality of prescribing, the fact that Discharge prescribing with too many doses, more than 20 was 25%. SR released products were 38%. 75% of the prescriptions were initiated and the patient hadn't even been on an opioid. So we had some real issues around that. Now this one was the one that excites the doctors most, the whole damage at discharge, because they feel that's where the real potential for harm comes in. So from a doctor motivational perspective, we got more motivation for that one. So we've put a lot of processes in place, and we'll repeat our quality prescribing audit. We're still trying to define our baseline harm audit, so we're still in the naughty corner as far as health quality and safety are concerned around our baseline data, because that is a challenge for everyone. I see there's a few other people who are indicating that they might be over there too. However, our oxycodone prescribing in 2013, the percentage of oxycodone prescribing as a full part of our opiate prescribing is 21.85%, and I'm pleased to announce today it's down to 9.47%. So we have actually achieved a 50% reduction. Now, I felt that we couldn't not make the most of this focus from health quality and safety and the collaborative work not to do something about that, because it was a problem for us. So we can't identify the harm there, but we've made a change that we know is better. Lessons learnt. Baseline challenges. We've had great focus and commitment. We've had a great multidisciplinary team. I think it's helped that we had 3 aims, because it was bigger and it was a bit ambitious, so it touched more people. We didn't stop on our constipation process measures just in the orthopaedic ward. We had a campaign with our posters to go everywhere, because we thought we'll just measure the orthopaedic ward, but we'll do it across the whole hospital. The induction, the training, the fact that it's there. We've got protocols now for constipation-induced harm and also for oxycodone prescribing. So we've still got trigger tool data to develop. We've got our patient leaflet, which we still have to develop. We want to make much more use of dashboards and newsletters. And we've got to repeat our quality prescribing. So we feel, I know I'm over time, we feel it's sustainable. But I do think there's a challenge to health quality and safety here. We've all talked about resourcing, and I think that they don't appreciate the power health quality and safety has in making it clear to the DHBs around expectations. So I'd like you to evoke that power a little bit more.